Considering all the different treatment options available, Jeff, what do you recommend should be our goals of treatment for using the variety of medications?
So I think that most guidelines and most people that practically think this through, the first line therapy would be over-the-counters. And I think that a lot of patients first actually seek out a pharmacist, or they self-treat. They may go to some kind of community variety store or whatever and pick up something like Senna or Docusate. And that's fine if it works. But one of the things we want to try and avoid is the anxiety that's associated with this, and the constant thinking about what's going to happen. Am I going to get stuck out of the house? Or the pain associated with it, the discomfort. And so I think that we want to decrease the anxiety. We certainly want to decrease the discomfort. And a big thing that I think is that we don't really want to chase after the constipation. The idea is that if the patient is on chronic opioid therapy, we want to the extent that we're able, prevent it. And if OTC laxatives work, that's fine. But if they don't work, I think we need to look to the next step, which could be a Pomora, in order to basically lessen the burden on the patients.
I would wonder, when will the guidelines change? Why don't we use what we know works rather than going through all the steps? We know we can have some benefit from it, but we're still seeing people follow guidelines, which we're told to do. But the guidelines make a Pomora basically a third or fourth line therapy.
I'm glad you brought that up. So in 2015, the American Academy of Pain Medicine put out consensus guidelines on how to treat opioid-induced constipation. And you're right, they were kind of third line, but in those guidelines, they actually looked at the bowel function index, which is also sort of a guideline. It's a 3-question questionnaire where the patients rate various parameters on a scale of 0 to 10, 0 being the least problematic. 0 to 100. 0 being the least problematic and 100 being the most problematic. And in those guidelines, you really didn't have to go through all these other therapies. If you reached 30 or greater, then you were a candidate for a Pomora. And I think that most guidelines now agree with that.
Well, until the guidelines change, certainly we're still in this predicament. Sometimes prevention is the best treatment. Rick, I might ask you, what are things we can be telling patients about to even prevent getting to this place?
So I think there are some prophylactic things that we shouldn't forget about. And while we want to think they can't be effective, it's been my experience they can. For instance, just drinking more fluids, trying to hydrate yourself better, can offset some of the constipation effects of just people with either idiopathic constipation or opioid-induced constipation. So it's not always a all or none phenomenon. So I think that's one of the simplest things. I live in the Southeast where people tend to get dehydrated, particularly in the summer. We have the highest incidence of kidney stones as well, but similarly, this dehydration does affect them that way when it comes to constipation. Another area is just, and this is difficult with some of our chronic pain patients, but if we can get them to be more active, right? So activity can help in a lot of ways. And we want our pain patients to be active anyway, right? We think that's good for them for a lot of reasons. So I try to sort of piggyback on the fact that not only might help strengthen them, help some core things, and help somewhat with their chronic pain, but it may help with the constipation. And then thirdly, before you even go to OTCs, just your own diet, increasing fiber in your diet, increasing bulk, that way can help. We're not exactly a country that always does a really good job in our diet of foods that can help just with our gut. And so I think there are things we can do, and I think sometimes they can surprise all of us with their efficacy, but a lot of times they fail as well, particularly with OIC.
And you're spot on that this is a catch-22 and a vicious circle. It's an at-risk population for nausea that doesn't want to take as much in. It's one that doesn't get up and move as much possibly because of their pain, and also one that doesn't want to go far from the restroom because of the embarrassment.
It's interesting. So you brought up fiber, right? And so I got to tell you, I have a lot of patients that come in and they say to me, I've read that it's good to increase fiber, so I've been taking psyllium. And one of the big issues is that if these patients don't drink a whole lot of water, and they use psyllium, it will make opioid-induced constipation worse because it's kind of like mixing cement. You take this powder and you don't put enough water in it, it's a problem. And so I actually try and stay away from psyllium unless I know that the patient's going to force fluids.
Well, and that's a really important, distinction to make when you're looking at, because I think often clinicians tend to put together OIC with idiopathic constipation. And it's really important to differentiate between those two diagnoses because the treatments can be different.
Yeah, Teresa, I think that's a great point, and to be honest, in the studies, when we sometimes look at the results and they're not as impactful, so to speak, as we think they should be, I've heard gastroenterologists tell me part of that is because of just the underlying incidence of idiopathic constipation. So these drugs, as we know, at least the true Pamoras, will not reverse idiopathic constipation. So it stands to reason that some of our patients with OIC also suffer from idiopathic constipation. We got to keep those two diagnoses in our head and realize that they can coexist as well.
Absolutely.
And to piggyback on that, one of the things that I see a whole lot, particularly in the pain community that's taking opioids on a regular basis, they may have skeletal muscle pain, they may have a neuropathic pain and/or a sleeping disorder. So it's not uncommon to have a patient that truly has opioid-induced constipation, but on top of that, they're on cyclobenzaprine, for skeletal muscle, which has a tremendous amount of anticholinergic properties. And on top of that, they're on a TCA like amitriptyline, which chemically is identical to cyclobenzaprine, except for a single bond in the middle ring. So it's basically doubling up on the drug,
Absolutely.
right?
Yeah.
And then you may have a patient that has urinary frequency, and so they're on a drug for that. And so a lot of times we have patients with opioid-induced constipation, and if we can sort of eliminate or reduce all these other drugs that are causing constipation by another mechanism, that could be really helpful too.
Mm-hmm. Mm-hmm.
Absolutely.
And maybe that goes back to the guidelines.
Right?
Maybe that says, are we going to try and reduce other things? We're going to try to treat the other type of constipation as opposed to figuring out if it's an opioid-induced constipation. So we'll go down the checklist and treat other types of constipation before we get there.
Right, and of course there's no overlap too. There's patients that truly have OIC.
Absolutely.
Right.
So to continue on in this whole thing, the big push in emergency medicine right now is what's called the ALTO movement, which is the alternative to opiates, which is add in all these other things to try and stay away from the opiates. Whereas that's well and good if it keeps you away from the opiates, but just adding more things on top of the opiates is not the right answer.